I do have to make one correction from Chris. I am not the founder of the Kempton Group. I am the second generation. My father founded the company the year I was born in '69, and I'm also very happy to announce that third generation is in the house. So, yeah. But with that being said, wow, what a conference that we have had this year. It seems to get better and better. But without each and every one of you, the FMMA would not be what it is today. We cannot thank enough each and every one of you for your actions within the movement and also your continued support. Keith and I are always very humbled each year to see how the free market movement in healthcare continues to grow, not just in number, but also in its influence on others in the industry. Each of you are a living embodiment of that influence. A few shout outs, we've done it before, but it can't be really overstated, and that is I want to thank the entire Connections team. They pull off an amazing conference every year. This one is no exception. They do such a great job, they make it look easy, but I can assure you it is not easy. So thank you all very, very much. Also a shout out to the AV team. They have done a great job. Marshall, you are keeping the trains running on time. You keep them well lit and well heard. So thank you. Also, special thanks to my rock star co-workers at the Kempton Group. We can think of them as the extenders, little primary care lingo there for you. They're really the extenders for the Connection team at the conference each year. Also, my partner in this free market journey, Dr. Keith Smith and his beautiful wife, Darla. Thank you all. Lastly, I want to recognize my beautiful wife, Kelly, who many of you all know. Kelly keeps me in line and on track. I know a few of you can also personally appreciate that skill of hers as well. Thank you, honey, I love you. I usually start thinking about my remarks for next year's keynote about a week after the current conference concludes. Sometimes next year's topic comes immediately, other times not so much. Sometimes I must wait for the right inspiration to strike me. Over the last year though, working with clients and prospects from all corners of the country, I keep coming back to a single undeniable truth that underpins the monopolistic control that we are all fighting against. And that truth is that the most reliable weapon the healthcare cartel wields against employers, patients, and even well-intentioned physicians, it's not regulation, it's not legislation, it's not lobbying efforts. It's really the naivete of the buyer. Notice, I did not say the ignorance of the buyer, even though sometimes that does play a role. No, it is something more insidious. Naivete. By definition, naivete is being too ready to believe someone or something or to trust that someone's intentions are good, many times because of a lack of experience or understanding. And let's be honest, that definition fits a lot of people in this country when it comes to dealing with the U.S. healthcare system. We assume hospitals, for instance, are pillars of the community. We assume that they operate with integrity and that they are benevolent and that their goal is to serve patients in their community above all else. After all, that is what the billboards and TV commercials say. But that is an assumption that is unfortunately outdated and dangerous. 2 generations ago, most physicians were likely to be in private practice, admitting patients to the hospital of their choice based on the physician's trust in the facility's quality and efficiency. The physician was a patient advocate in the truest sense, considering not just medical outcomes, infection rates, and the quality of the nursing staff, but also the financial costs. Because insurers back then, they offered defined benefit plans that usually would limit payouts to a specific scheduled amount. The physician earned and deserved the trust of their patients and their community. And by extension, the hospitals did too. If a particular hospital wasn't the right fit for your particular needs as a patient at that time, your physician would choose a different hospital. But today, that model is all but gone. FMMA member physicians are happily excluded from this. No, most physicians in America are no longer in private practice. They're employees, hired hands of large vertically integrated hospital systems, executing corporate policy like any other good employee that wants to keep their job. Many of those hospital systems aren't even owned or managed locally. They are part of sprawling corporate bureaucracies, often headquartered states away, making decisions based not on patient care, but on financial models. The community hospital, once a local institution and pillar of the community, now operates more like the branch of a megabank. Employers who think they can negotiate directly with their, quote, local hospital quickly discover that the real decision-making power resides in a corporate boardroom far removed from their community. We run into this right here in Oklahoma City. Several of our hospitals have empowered someone like an officer of payer strategy or similar title to negotiate and execute single case agreements or single patient agreements with an employer. But these people do not have the authority to put together a comprehensive direct contract / relationship with an employer or their third-party administrator. Those types of decisions must run through the machine and fit within the overall corporate strategy in which a local employer or independent third-party administrator is rarely a part of. The large systems default to the large carriers and other card-carrying cartel members, simply overlooked or actively disregarded. Either way, that doesn't sound very community-focused to me. And what about the physicians themselves? Many employed physicians remain blissfully unaware of the financial exploitation their hospital employers engage in. They are shielded from the revenue cycle, the billing schemes, and the price gouging tactics that make healthcare unaffordable and largely unaccountable. They often have no idea that their routine surgical procedures cost 3, 5, 10 times more at their employer's hospital than at an independent facility. Bear in mind, as an employed surgeon will likely only be paid a relatively small sliver of this egregious bill. They don't see the outrageous facility fees tacked on to a simple outpatient visit or surgery. They are insulated from the harsh reality that their employer is maliciously extracting large amounts of wealth from the very patients that they have sworn to heal. Some physicians, when confronted with these facts, refuse to believe them. They have been led to think that any lower-cost competitor must be cutting corners, must be somehow sacrificing quality. They've bought into the narrative that their hospital employer is the only safe, reasonable choice for patient care, and that the cost that is charged must be the cost. But the reality is that many hospitals are not benevolent institutions any longer. They are highly aggressive, predatory entities that will not negotiate in good faith with employers or their TPAs unless forced to do so under the threat of losing market share. To add to this, many employed physicians don't understand the direct harm their employers' financial strategies cause to their community. They are not taught about hospital charge masters, predatory billing practices, or my favorite, the illusory discounts that they offer. nor do they understand the financial ruin that patients and self-funded employers endure. The collection strategies and practices from some of these egregious bills that are directed at patients are nothing short of draconian. Threatening financial ruin to patients is a core tactic, even if the bill is in dispute or the price completely unreasonable. Some only learn these painful truths once they leave employment at their hospital and start working with an independent facility, or when one of their own family members receives an astronomical bill. Until that awakening happens, they remain unwitting accomplices in a system that exploits the very people that they have dedicated their lives to care for. There are a lot of reasons that this behavior persists. We believe here at the FMMA that much of this is due to the continuing unfounded trust in the benevolence of the corporate hospital. I think at this point, I probably should say that we are not anti-hospital. We're not anti-anyone. We simply believe that all players in the market should be subject to the judgment of the market. Hospitals, third-party administrators, physicians, benefit consultants, pharmacy benefit managers, etc., should all be included. Hospitals should not be immune to the harsh judgment of the market. They are not special or different, but they are important. Patients and families count on hospitals in their most vulnerable times. They are trusted, but they should also be trustworthy. I'm born and raised here in Oklahoma, and I know a lot of you are thinking, well, that explains a lot. But I was taught by my parents that where much is given, much is required. When talking about hospital systems, I certainly think this should apply. Every day at the Kempton Group, we interact with employers regarding their benefit plan. I'm very blessed to be able to work almost exclusively with benevolent employers. They all have a few things in common. One is that they all want the absolute best health care for their employees and their dependents at the most affordable price possible. The other thing that they all have in common is that they all want to support their local hospital. When we talk to them about the overall cost of their benefit plan and then discuss the fact that what they're paying to their local hospital is excessive or is not comparable to the price from a free market provider, we usually hear, yeah, but we have a great relationship with our local hospital. Do you? Or do you just have a relationship that benefits them? A hospital may be friendly in conversation, but that doesn't mean that they're offering you a fair and reasonable price. In most cases, the relationship is one-sided, with the hospital extracting maximum benefit from employers, while employers struggle simply to control costs and provide a good living to their employees. Since 2011, my TPA has been very aggressive in seeking out high-value medical professionals in facilities like Surgery Center of Oklahoma who are upfront and transparent with their pricing. We actively navigate and incentivize our clients' plan participants to seek and utilize these lower cost, higher quality options. Sometimes these high value options may not currently be available in the employer's local market. They may be located 20 or 200 miles away from the local hospital options. The irony is that the local hospital may very well have actively colluded with the insurance carriers in the past to drive those smaller independent options out of the market. When faced with the idea of travel or even navigating to other local options that is not a part of the hospital system, we commonly hear from prospects, not necessarily clients, but prospects, that we don't want to disrupt our employees' access to care. But what is access if it leads to financial ruin? Employees need access to high quality, cost-effective care, not just whatever is most convenient for the hospital. Employers who take the initiative to steer employees to higher value providers often find that their workforce benefits from better care at a fraction of the cost. Additionally, many HR professionals resist these changes because they're trained to prioritize ease of use and employee happiness and satisfaction above all else. The large predatory hospitals, insurance companies, and many in the legacy benefits consulting world understand this desire and exploit it. They design benefits to be simple on the surface, while embedding hidden costs, inflated pricing, and inefficiencies that drain employer resources. HR professionals, often acting in good faith, resist disruption because they fear of being perceived as making benefits too complicated or causing too much noise. But here's the reality. True leadership in benefits management isn't about avoiding noise. It's about making strategic, sometimes difficult choices that serve employees in the long run. A system that is easy today but financially devastating tomorrow is not a good system. Employers and consultants must educate these HR teams on the broader economic realities and empower them to take a stand against these manipulative tactics that are draining employer resources and making them less competitive. One of the biggest hurdles in implementing a free market healthcare strategy is overcoming employee objections. Many employees balk at having to do more when seeking medical care. Patients in the U.S. have been conditioned to think about healthcare differently than any other service or good that they purchase. Unlike any other aspect of their lives where they routinely compare prices, read reviews, and make cost-benefit decisions, healthcare, in contrast, is seen as an entitlement, a black box where prices are unknowable, unimportant, and independent discernment is discouraged. This entitlement mindset has been carefully cultivated. Insurance companies and hospitals have spent decades reinforcing the idea that patients shouldn't have to worry about cost, that someone else, employers, insurers, or the government, have that handled. This has led to an expectation that healthcare should be frictionless and that any effort required by the patient is an unfair and unreasonable burden. The result? Patients are easy to manipulate. They demand access to the most expensive hospitals without questioning why those facilities cost so much more. They equate cost with quality, despite overwhelming evidence that independent providers often offer much better outcomes at much lower prices. This easy button mentality has made patients passive participants in their own healthcare, which benefits the cartel immensely. Employees may, that's why I write this stuff down. Employees may resist price shopping and scheduling through a new system, or talking to a navigator, or using alternative providers. They may view these changes as an unnecessary inconvenience rather than an improvement. This resistance is often fueled by a lack of understanding about how the current system is exploiting them. Employers must educate employees on why these changes are beneficial. This means clear communication, real-world examples, and financial incentives. If employees understand that taking an extra step to choose a high-value provider can save them hundreds or even thousands of dollars in out-of-pocket costs, their perspective starts to shift. Saving money for an employer's self-funded plan also improves the employer's bottom line, which directly and indirectly benefits the employees. Employers should also implement concierge services and/or navigation tools to streamline the process and minimize any perceived burden. Please notice, I said minimize, not eliminate. The hard truth is if we want to regain control and make healthcare more responsive to the buyer, patients are going to have to engage. Hospitals are highly skilled at using the patient as a tool to provide leverage against the employer and their benefit plan. When a patient attempts to engage in the appropriate role of a buyer and inquires about cost or how they're being treated, many times they are met with contempt and told, if you only had better insurance, you wouldn't have to worry about these things. After care is provided, if there's a dispute about what was charged or the reasonableness of that cost, the patient is ultimately confronted with the not-so-veiled threat of, if your insurance doesn't pay this bill, you will be held financially responsible. The patient is made to think neither they nor their employer's health plan has any right to question the hospital regarding appropriateness or cost. And if they insist on it, you, the patient, will be financially punished. An example of an employer that has grown to understand this is Tower Extrusions. Tower Extrusions is an aluminum extrusion manufacturer based in Olney, Texas, which is just south of Wichita Falls, Texas. They are also our Beacon Award winner for 2025. Mark, their CEO, Laurie, their consultant, and I did a breakout session yesterday to go over the entire Tower story in depth. Many of you attended this session. If you missed it, once all the videos of this conference come out, their story is definitely worth your time to look up and check out. Tower, as a self-funded plan sponsor, was facing unsustainable cost increases and had tried numerous times to negotiate and get a reasonable deal from the dominant hospital in their local market in Wichita Falls. This hospital is widely known as an aggressive biller with very high overall charges. Tower had tried multiple strategies to try to deal with this system. First, they tried to find the best network they could. This network they found assured them that they had the best discounts you can possibly get in the area with this hospital. That strategy failed. They tried using reference-based pricing, which uses a percentage above the hospital's Medicare reimbursement as a basis for payment, instead of using a network to try to get fairer treatment. That worked from a pricing standpoint, but it was like walking into a buzzsaw, as Mark said. This hospital used all of the techniques that I mentioned earlier, like driving a wedge between Tower's employees and Tower. Patients were regularly told by this hospital that your employer is cheap and they have a substandard insurance plan. Then they aggressively pursued Tower's employees and dependents for the difference between what Tower felt, based on their research, was a reasonable reimbursement and the hospital's full billed charges. These were not small numbers, and normally nobody pays full billed charges. However, in this market, if you dared to defy the business model imposed by the local hospital, they would demand directly from patients full billed charges. The goal was to incite a revolt among Tower's workforce, thereby making it as painful as possible for Tower so they would be forced to get back in line and rejoin the cartel. I mean, a carrier network. The hospital strategy worked for a time. Tower went back to the perceived safety of a carrier network, but continued to stand by and watch their costs go up and up to unsustainable levels. Tower eventually prevailed by getting much more creative. Since then, they've returned to a reference-based pricing plan design, but they aggressively seek out direct contracts with more reasonable healthcare providers in their area whenever possible. The medical providers in Tower's area all know now that they have competition, and they must respond accordingly. If they can't get a local provider to step up and offer competitive pricing, Tower has no problem paying for employees to travel the 188 miles to Oklahoma City, where there are many options for bundled market-based care. Tower has even employed a free market-friendly PPO network for a couple of their locations closer to the Dallas-Fort Worth area. They use the market-dominant local hospital I spoke of only when absolutely necessary. They have largely stopped feeding the beast, as our friend Matt Ort likes to call it. That was financially damaging their health plan and, by extension, Tower's workforce. They have employed a small team of nurses at Tower, led by a rock star nurse named Jonna, who may be here in the audience. Jonna's team works for Tower and their employees. They also work very closely with their independent third-party administrator, the Kempton Group, who also works for Tower and Tower's employees. They also have a brilliant independent consultant who also works for Tower. Tower has built an extremely effective team, and they now run their health plan the way they run their core business, actively, not passively. Is this more work? Yep. Is it effective in lowering costs and improving the health of their workforce? You bet. Are they naive anymore? No, they are not. I know that Tower hopes that someday their local hospital comes around and becomes a better, more affordable, more responsive partner. And you never know, things may be changing. But the best way to accelerate that change is for other employers in that market to also wake up and choose differently, and some are. Employers in that market are getting very tired of being taken for granted. They are looking forward to a day in which their local hospital works for them, not the other way around. When local self-funded employers demand more value, lower cost, and higher quality as a condition to trade with them, they can ignite real change in their community's healthcare landscape. Hospitals only respond when they see their market share slipping. If enough employers redirect employees to independent, high-value providers, hospitals will be forced to compete on price and quality. Now, this is not theoretical. It's already happening in pockets across the country, as the previous example illustrates. Now, this process takes time. Hospitals move slowly. You have to be willing to disrupt their referral patterns for an extended period of time. These hospitals have to feel the impact. Even if you're a small employer and give it enough time, the hospitals will eventually figure out what's happening to them. Now, this can take months, if not longer. We've recently been successful with a direct agreement with a large, aggressive hospital system here in Oklahoma. We've been battling and directing cases away from them for almost a decade before they finally came to the table in good faith. If you want a closer, more mutually beneficial relationship with a local hospital, you must show them that you have options and you are willing to exercise them. I know what you may be thinking. I don't have the resources or experience to do what Tower did. And as an employer, you may be correct. However, for smaller companies, there are wonderful resources for hire to largely accomplish what Tower did. Choosing the right solution providers and making sure that you understand their motivations is important. Pay careful attention to how solution vendors are paid. If they get paid on a percentage of savings, or even worse, a percentage of billed charges, what is their motivation to help you to work with high-value, low-cost medical providers? If the vendor gets paid when your employees make bad choices, and then they're able to save you money despite a bad choice, what motivation do they have to help you form better relationships in the medical community and then train your employees to make better choices? The answer is they don't. A reasonable per employee per month arrangement is a much better compensation strategy, but even that must be combined with accountability and results. Engaging with a direct primary care clinic is also a wonderful idea. Independent DPCs can achieve the same or even better results by acting as a quarterback for medical care and referral decisions. Effective DPC needs to work closely with other professionals engaged by the benefit plan, such as the TPA, the consultant, and legal counsel. Benefit plans work with tax-advantaged monies, so doing it right is not optional. It's critical. It takes a team of professionals. Lastly, setting appropriate expectations with employees, HR, and the C-suite are also critical. The easy button is well established and is a proven failure. As I said earlier, the cartel wields the easy button as an effective tool to lull HR and employees into just trusting them, to handle the complexity and cost to your own detriment. No, an engaged patient and HR team must have the knowledge of how to be a better consumer, but they must also understand how the game is rigged against them. An effective benefit plan that maintains affordability and offers high quality is work. Not unlike choosing any other major purchase in our lives, healthcare is not different. So, the time for naivete is over. Hospitals won't change out of goodwill, and the insurers will not prioritize your interests over their profits. The only way forward is for employers, independent medical providers, and free market advocates to force change, not by asking nicely, but by taking decisive action. You have financial leverage. Use it. Negotiate, demand transparency, redirect employees to high-value providers, make hospital systems and others in the healthcare delivery system earn your business instead of giving it to them by default. If you're waiting for these institutions to act in your best interest, you're waiting for something that will never come. Real change does not come from policymakers. It does not come from hospitals voluntarily deciding to be fair. It comes from you, the employers, the business owners, the physicians, and the advocates who refuse to play by their rigged rules. This movement isn't about tweaking the system. It's about breaking the stranglehold of monopolistic control and building a system that serves patients, not corporations. So, as you leave this conference, I want you to ask yourselves this: are you going to keep playing their game, or are you ready to change the rules? Thank you.